everyone to this webinar from the Mental Health Services Learning Network of Australia and New Zealand, better known as THEMES. I'm Jane Austin, Executive Director of THEMES. THEMES acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past, present and emerging. Tēnā koutou katoa to everyone joining us from Aotearoa, New Zealand. We're opening our webinar series on this first day of Mental Health Month with what is admittedly a big question. What do effective mental health services look like? And in true THEMES tradition, we're bringing together the many different voices that could lead us to collective understanding, insight and action. If you're feeling distressed at any time during this conversation, please do seek support. For example, in Australia, you can call Beyond Blue on 1300 22 46 36, and in New Zealand, free call or text 1737. We only have an hour today, but we intend this to be the first in a series of constructive conversations in which all voices can be heard. I will now hand over to Natasha and the panel. Thank you.
Thank you so much, Jane. My name is Natasha Mitchell. I'm a journalist and broadcaster, have over many years made programs and hosted events around mental health. It's an issue that I care very, very deeply about. I'm so delighted to be able to convene this conversation. Do you know that there are nearly 600 of you joining us right now from across Australia and beyond? So a really warm welcome to you, the first THEMES webinar, one of a number that we hope to convene. And this is really about a conversation with you. So you can post your questions into the event portal and our focus will be doing our best job to get to all your questions. We have a mammoth topic to explore today. And I think that the fact that 600 of you have tuned in to this event is a real testimony, don't you think, to how much concern and hope and frustration we all feel about the question we're here to discuss together. If Australia's mental health system is failing us when we are most in need, what then do effective mental health services look like? That's our question today. And I would add, how do we create services that are available when we really need them, that help us prevent a crisis before it happens, that respond to us with humanity and as a whole person, that understands the complexity of our lives and all our needs, that involve us fully in decisions, that focus on recovery and our hopes and our aspirations for ourselves. And also, how do service providers feel supported to offer all that in the work that they do without feeling overwhelmed and overburdened and dissatisfied with the fact that they can't give the full measure of care that they want to. I also want to acknowledge that part of this event is about the timing of this event comes off the back of a Four Corners program that was aired across Australia, which focused on homicide cases, which gave a platform to the pain and the distress of carers and family members. The documentary did, I think we'd all agree, address some difficult and important issues, but it also triggered a lot of grief and a lot of distress and a lot of anger and frustration amongst many of you who live with mental illness. You felt it was stigmatising aspects of it, missing were your voices, and I guess there wasn't a whole lot of focus on solutions. So what we want to do over the next hour is focus on solutions. What can we actually put in place? What needs to be put in place? So we've got Paula Hanlon joining us. Hi, Paula.
Hey, hello.
Care worker for 23 years in the public sector community health, mental health service in New South Wales. She brings her own experience as a mental health service user. Yes. She's also an assessor for the Australian Council on Healthcare Standards, which means she reviews mental health services across Australia. And she's also spent the day at the other warm line. Lisa Sweeney is with us. She's Head of Policy and Advocacy for SANE Australia. Hi, Lisa.
Hello.
She's also has lived experience of mental illness and is a carer for family members with psychosis. She's worked in various government policy and research roles, many hats. Patrick McGorry is with us. Hi, Pat.
Hi, Natasha.
Psychiatrist Patrick McGorry, Executive Director of Origin and Professor of Youth Mental Health at the Centre for Youth Mental Health at the Uni of Melbourne. He is a founding director of Headspace, which serves our youth across Australia. Simon, hello, Simon Stafrace, a psychiatrist currently seconded to the role of Chief Advisor to Mental Health Reform Victoria, implementing the recommendations of the whopping Royal Commission to Victoria's mental health system. He heads up a mental health service at Alfred Health in his usual role. Welcome, Simon.
Thank you. Welcome.
Okay, we can see your questions coming in on the event portal. Don't hold back. Please do post them there. Anything that comes to mind that you'd like our panel to address. And I just want to start for all of you, really. You know, many years ago, we shut down the big hospitals and we reorientated the mental health system towards community-based support and care. And I think what we've observed and what we've experienced is that it's patchy in its delivery. It's not comprehensive. It's under-resourced and it doesn't integrate across multiple services. So I want to hear from each of your own perspectives. What would strong community-based support and care look like for you? Paula.
Thanks, Natasha. Well, firstly, I have to say a more effective peer workforce that is funded specifically for peer workforce, because at the moment some of our positions are funded from clinical roles that haven't been filled. That's not effective or efficient. Because there's so much to say, I'm not going to dwell a lot on each of them. Also, we do need efficient ratios. I read an article during the week which talked about clinical ratios, and when it got to community mental health, they said, oh no, this isn't something that can be done. Well, you know, that's BS, because you know, I've observed a really good mental health service in rural Victoria, I will say that, that did have ratios, and it was the best service I've ever seen. They had a ratio of 13:1. Every
Just
person...
explain what you mean by ratios, Paula.
Oh, sorry. So there was 13 people to one clinician. And so each person, they had all the planning in their files. They had wellness plans. They were very comfortable in the flow through process. So from admission to discharge, so that there wasn't people clogging up the system. There was a clear flow through. The people, I spoke with the people and their families, and they were very comfortable with how to access the services. So I saw that actually working. So that was good. We need services that are more trauma in practice. So trauma informed, we've had so much training with service providers around what trauma informed care is. What we need now is clinicians that can take the next step, that can ask the question, have you got trauma? Because most of us do. And some of us have very extensive complex trauma. And the clinicians at the moment, they're just not, some of them are just not comfortable in going there. So we need to skill them up. We need to help them to develop some therapy techniques where they feel comfortable in actually helping somebody. And yeah, so I'll stop there because I don't want to take up too much time.
And we'll come back to you, but the peer worker
Yes.
conversation is a really vital one, because that's where we start to see ourselves in other people's life trajectories, don't we? When you're in a system and you're struggling and you're at crisis, you need to see other people who have been there before you, who can talk to your experience in a sense.
Very much so. It makes a huge difference when we can connect with somebody else, and there's that sense of hope, because we lose all sense of hope when we become unwell. And to talk with somebody who's actually achieved a measure of recovery and understands that process just automatically gives us that sense that, oh, I can do that as well. I remember the first time I saw my mentor speak, I thought, wow, she has mental illness. I could never do that, but I'm doing it now. So, you know, we've, mentors and having people that we can share with, it's really, really important.
Hope.
Hope
come back
is
to
central.
that. Okay, your questions are coming in and I'm going to come to them very soon. Lisa, what kind of things would you like to see to really realise the vision for community-based support and care?
Yeah, well, definitely building on, I totally agree around the point of increasing the availability of the peer workforce and really embedding trauma-informed practice, you know, as opposed to just kind of the ideology of it, which I think is fairly well accepted, but we're still not seeing it actually implemented properly in services. I think when I think about community-based treatment and what the aspiration was when the institutions closed down, I would really like to see a system that can support someone throughout the continuum of their mental health experience. So a community-based system that is capable of responding in acute stress. I don't think it's an option for everyone to avoid hospital all of the time. I think we should definitely be aiming for as many people as possible to be treated and supported within the community, within their home setting. Really that kind of wraparound care that supports someone no matter where they're at on that mental health continuum. That's probably my first big thing. And the second thing, I guess, coming at it through the lens of a carer or someone who supports loved ones with a lived experience, I would really like to see improved partnerships of care that, you know, between health service, a person with lived experience and whoever their support network or community is. So those are probably my two big ticket items.
Yes, the role of the carer or the supporter or the partner or the child who is supporting the person who's accessing the service is so vital. And I think some of your questions might reflect that. Pat, I want to go straight to you on a question that's come in rather than responding to that broad question, if that's okay. But Catherine, let me just see. We had a question here from Brooke. How can we get more of a focus on preventative services before crises happen and before hospitalisation is necessary? Now, that's right core to your concerns and interests, isn't it?
Yeah, absolutely, Natasha. It's a great question. And I mean, we've spent the last 25 years trying to develop, you know, early intervention in mental health, basically, which means that because of the incredible neglect and underfunding, people only end up getting treatment under very adverse conditions at a very late stage. You know, it's all ambulances at the bottom of the cliff, isn't it? And that's why there seems to be so much more need for emergency department and acute sort of care than if we had actually invested properly in that community, that proactive community-based sort of model. And I think the reason for that was that, you know, we got rid of one hospital system, which I trained in, the old mental hospital system, and we replaced it with another hospital system. So we had big acute hospitals running, you know, services of which most of the need was in the community, but they also ran the beds, but it was all run from within the institution, within a new institution, namely, you know, an LHD or an LHN. So replaced one institutional structure with another, and the second one has really not understood what community mental health actually needs to be. So that's partly an answer to the first question. But intervening early, we know that if you recognise the early signs of a potentially serious mental health condition, we've got really good evidence now. You can really change the course of those illnesses if you pick them up early, and you often need to provide much less, I suppose, what's the word, invasive or difficult forms of treatment. You know, we've found that you can even just with pure psychosocial treatments alone reduce the risk of transition to psychosis if you diagnose these conditions early. So early intervention's got really great evidence. It's really the secret weapon that we have, and the same logic applies to, say, recurrences or relapses of existing conditions. Obviously, you want to pick those up at the earliest possible stage in the community, where you can respond in a safe and trusted setting. You know, like and this concept of community hubs has become very popular. And you want those places to be very soft entry. In other words, they want to feel very accessible, very welcoming, very compassionate, as you said in your introduction. They've got to be
not punitive and not necessarily even medicalised.
Well, yeah, exactly. So in the youth area, what we have is this concept of this youth cafe style sort of entry point where you have a foyer really where you can just kind of drop in and just basically get comfortable before you talk to anyone. You want to have peer workers and volunteers in that space who basically make the bridge to the clinicians who are sitting more in the background. And I've seen these models being developed within Australia and also in many countries in Western Europe in the youth area. And they would work very well across the lifespan, because trust is the big thing. Can you trust the person I'm going to share my story with? And will they understand? Will they help me? And trust is the very important thing. The peer workers are, as Paula and Lisa said, are very, very important there. And don't forget that probably a third of the clinicians have got lived experience as well, and 100% of them have got lived experience in their families. So in a way, this distinction between us and them is not good at any level. So I think if we can think that way, in an inclusive way about all of this, it's one of the secrets, actually.
Yeah, and trust is everything, isn't it? And trust is part of these sorts of conversations, because people do lose trust because they lose agency when they enter the system. And on that note, Simon, I'm struck by Claire's question here. Why can't the system stop being a system and society take responsibility for the community we live in? Support workers, mentors and paid clinicians do not substitute for actual connection and de-isolation. Now, I think that's a particularly vital question for the times that we're living in during this pandemic. Hello from lockdown Melbourne.
Yep.
But for you, as you sit inside the Royal Commission into the mental health system in Victoria and all the inputs that have come in to describe the system and its failings, you know, ultimately this is about connection and isolation, isn't it?
Well, connection. Thanks, Natasha, for the question. I think it was Claire who posed the question. Is that right? So thank you, Claire, for the question. Social connection is a really critical element, I think, in mental health and well-being. And there's you may be familiar with some research that was conducted in Australia on a group of 1,800 people suffering from psychosis, which identified social isolation and loneliness as being the second most common barrier to recovery that was identified by those people in interviews. And when I first saw that piece of data, I was really quite taken aback because, it struck me that in many of our systems, of course, social connection is not necessarily a primary sort of outcome that is sought, and to sort of think that it is identified as such a major barrier to recovery, and yet is ignored and neglected by the system more broadly, really, I think, brings home this notion, or at least this question: do we, is the system designed in the right way?
And so, for you, as someone inside the system and responsible for a mental health service, do you feel able to reach in and support people in the wider community beyond your service?
Well,
looking at questions like social connection, housing, employment.
Yep. So I think I'd just like to reflect just back a bit on the question that Claire asked, which is why can't the community take more responsibility? Why can't mental health be everybody's responsibility? Because I was thinking about the question that the original sort of question that was posed. What do effective mental health services look like? And I suppose the starting point really is that they have to be embedded within a community that cares about mental health and well-being. This, I think it's one of the phenomena that has emerged, I suppose, out of COVID is this notion of we're all in it together, and it does beg the question: should the slogan "we're all in it together" only be something that we adopt during a pandemic, or does it actually apply at other times as well? And so how do we create communities that are more connected? And so there's a really interesting piece here, and I think modern mental health services have to be increasingly embedded within their local communities. I think this notion of a mental health service as isolated, sitting in the ivory tower, is one that that we need to sort of challenge. And I think that that we've seen a lot of work. When mental health services were set up after deinstitutionalization, the concept of community mental health care was not particularly well developed. And I think we've learned so much over the past 20, 25 years. And we're in a much better position now to understand that not only should services be delivering clinical interventions, but they've also got to be intersecting with social determinants as well. They've got to be engaged in the problem of finding housing for people, of helping people to develop social connections, employment, vocational activity. The notion of the person with mental illness as somehow being a clinical entity. This doesn't make sense. We know that people are have multiple facets, have multiple interests, and it's vital, I think, that services connect with all of them.
Yes, so the challenge is how, but we're getting lots of questions around human rights. So I definitely want to come to those questions because it's such a vital aspect of the experience of, some would describe survivors of mental health systems. So Mark has asked, Paula, as a true champion, we're getting lots of questions about peer workers as well. Mark has asked, Paula, as a true champion for the lived experience workforce, how can peer workers achieve systemic change when they are employed by the systems they are trying to change?
Okay. Comes back to that partnership and working together and being true partners and having respect for everybody's opinion. So for the peer workers to respect the perspectives of the senior executives, and there is a whole process. A system is a difficult thing to maneuver within. One of the things that I've learned is for myself is to have external peer supervision. That has helped me survive 23 years, to have that support from a more senior person. To understand the system, to understand that things do move slowly, that there are reasons why things can't always be implemented, that a no may not be a no forever, it might just be not at this time. So we have to understand the system that we're a part of. I also believe that there isn't a conflict of interest because, we have accreditation. We have people that are employed to tell us about our services and where things can improve. And I see our role fits very nicely into that perspective as well. Plus, it's the benefits that we bring with that relationship with each of the people that come to us, that we are an important part of their journey. And we're also examples to the clinicians of how things can improve and progress for people. For the last few years, we've been having a living library in Mental Health Month in our service, and it's just been fantastic. Clinicians have come along and sat down with a consumer or a carer and talked and really got to understand what that person's life journey has been like. I think that's absolutely essential. Plus, we have to get in and be with the students in there, the nurses, the OTs, psychologists and social workers. We have to be in their training and helping them to develop from the start those practices and understand the principles of consumer participation.
Brooke has added, how can we get easier access to peer support workers across the board, not being so variable across different postcodes and local health networks?
There isn't enough, yes. Yeah, well, I often say that what we need in the peer workforce, and I can only speak for New South Wales because I don't know the systems in the other states as well, but we've had our Aboriginal workforce has got dedicated funding from Treasury, and that was established well. Our workforce was not set up like that. It has not been funded like that. So I think we need to really look at how our peer workforce is funded. I'm a sole worker at the moment in my service, and it's really hard being a sole worker. I do belong to a team across the LHD, but in my workplace at the moment, I'm a sole worker. I am actually in a different position for 6 months as part of a pilot, but I will be going back to that other job. But, you know, I should not be a sole worker. And I've got volunteers who do over 1,000 hours of volunteer a year, and that it just shouldn't happen.
Unpaid work, yeah.
Yeah, yeah.
Here's the thing, and how do we support the peer workers? So many questions coming in, so I'll keep them flowing your way. Lisa, we have this one from Graham, who says, why isn't there increasing community-based accommodation with 24 support for consumers with unresolved mental health conditions? Now, I mean, we certainly hear from service users and carers that when they most need the help, when it's really urgent, when things are really desperate, they might end up inside an acute facility of some sort or service, be medicated, and then they have to go home before they're really ready to disconnect from the service. And I wonder whether that question is relevant and whether you've got some thoughts there.
Yeah, the reason as to why that doesn't exist in the proportion that we need it to exist largely comes down to funding. So we do have step up and step down facilities here in Victoria and in other parts of the country. Prevention and recovery centres are what they're called here. But even those are terribly variable. There's not enough of them. They're not widely available across our state here in Victoria. And they're often for a duration which is dictated more by the services needs than it is by the individual's needs. So that's something that we really need to shift away from. So that doesn't become moving of the deck chairs based on a demand which the service is not funded to meet, but is really a person in distress together with their family and their treating team making a decision around what the duration of that care looks like. So it's definitely something based on my own family's experience, which I would love to see more of and more widely available. I don't think anyone would dispute that it is preferable in many instances to an acute inpatient setting. But ultimately it comes down to funding and the government prioritising that as that ultimately drives better outcomes and less distress. So yeah, would love to see more of that.
And there's examples too of peer-run services like that, which, how perfect is that?
The best of everything.
Yeah.
Patricia has written, wouldn't the burden on psych services be lifted to some degree by having counsellors be covered by Medicare? Counsellors can be preventative and an early intervention with low to mid-range issues before they spiral out of control. And that question, related themes have come up a number of times. That access to, you know, another one from Cormac, is a GP mental health care plan with access to 6 to 10 sessions, in all likelihood a CBT practitioner, appropriate for those with a history of trauma or complex trauma. So yes, a number of themes coming up around that better access to that kind of immediate help that we sometimes need to guide us through the chaos inside our lives and our minds.
Oh, look, those are fantastic questions. And one of the things we've got to expand the system incredibly. There's got to be a huge expansion at state and federal level, you know, and that's what we're hoping for, obviously, with the Royal Commission, which I'm also involved in, and I'm very confident that's going to occur in Victoria, but also federally. And so the front end, trying to get, we've been struggling this with COVID, with a surge in need for care with COVID, and the system's at capacity, the current system's at capacity. So we've got to look at new workforces. When the federal government put these pop-up adult hubs in Victoria, the 15 sort of rapidly implemented pop-up hubs, they're scrambling for workforce. So finding a new workforce, peer workers has been discussed a lot tonight. That's obviously a great new workforce that we need to invest in very heavily for all the reasons that Paula has been saying, you know. But we need to think about other workforces and task shifting, but also we don't want to throw the baby out with the bathwater either. We've got to respect specialisation too. So it has to be a seamless grading of expertise as according to people's needs, and they shouldn't have to go through triage systems or, you know, I always say that these things are really designed to keep people out, not get people in and engage them. So we've got to have new workforces, we've got to have new work practices. So I don't think it's okay for, and this might be a bit controversial, to invest really heavily in isolated individual private practices everywhere. I think we've got to build a system of team-based care where that's needed, you know, as well. And there hasn't been much structural leverage to sort of make that happen, really. And what has been built, as Simon was saying back in the 90s, was really not fit for purpose, and it's just fallen apart. You know, it's fallen apart in the face of the demand. So we've got to rebuild, but we've got to rebuild with new workforces and workforces we've never thought of before, actually.
Although Dave has asked, given the influx of peer workers into public services and recovery-orientated practices, is there a future for the medical model and the mental health nurse?
Well, look, you know, this is another one of these binary false dichotomies, you know, medical model. It's a very emotive term, isn't it? I mean, I wasn't trained in a medical model. I was trained in the biopsychosocial model, which included all of these diverse perspectives. We try to integrate and be inclusive about ways to help people, not say this, not that. No, I don't think that's helpful. So, but we've got to recognise that the way services have been provided has been very narrow and very, very excessively biomedical. So I agree with that, but we've got to expand our thinking and in all the ways that people are probably comfortable with.
Susie's commented, spiritual care can be part of the solution. It helps balance the medical model. We need to have more spiritual care practitioners in mental health wards and facilities. So there's another dimension. But Jessica asked, and I'll put this to Simon and anyone else who would like to pick up on it, when are mental health services going to eliminate restrictive practices and embrace real co-design, lived experience consumers?
Well,
Simon.
Funny you should say that. So I think it would be reasonable to say that mental health services have been making incredibly significant strides towards reducing restrictive practices. They're not there yet, but the situation today is very different to what it was 15 years ago, 20 years ago. We know there have been a few, we know that there is a way to go. We've had recent disasters in New South Wales and elsewhere, which are a reminder that, of course, we can never stop being vigilant about this. It's a complex issue because, of course, we have a system that has been designed in a particular way, and so eliminating restrictive practices overnight is something that would be quite difficult to achieve for a whole host of reasons.
But you do recognise the incredible distress that restrictive practices can create, and I guess
I do.
Concerns is that they can serve to re-traumatise an already traumatised.
They can, and I'm also sort of conscious of the fact that clinicians are having to deal with a huge range of challenges that can sometimes be quite difficult and very confronting. And I think we are working our way gradually towards reducing and hopefully one day eliminating restrictive interventions through improvements in design, through co-design of models of care, and through changes in practice. This is not something that will happen overnight, but we are absolutely committed to making significant strides towards elimination.
Paula, I'm interested in your perspective there. When we use these words co-design, I'll never forget a presentation that Faye Jackson gave a couple of years ago where she just really held the room to account and said, lip service.
Yes.
What does it actually look like to create services where people are designing them together with service users?
Yeah. Well, look at the designing of new mental health units. If we were around the table saying, this is what we need in a mental health unit, but we don't get asked because it comes down to the footprint of what's available on the land. It does, where they're not designed to be recovery focused places of healing, they're places of restrictive practice. We still don't have free access to sensory modulation, which is fantastic. I've got my oils with me, you know, like it's so important to have access to those things, to be able to go and grab a big huggy, you know, puppy dog or pussy cat, but you've got to ask, or, you know, or they're locked, or terrible. But yeah, and sorry, I've lost my train of thought there, but
yeah. So that notion
Natasha,
of co-design, that notion, and did
oh
someone
yeah,
want to
co-design. Yep.
Yeah, could I just come back to this? Because in Victoria at the moment we're in the process of commissioning 170 beds as a result of one of the recommendations of the Royal Commission, and we are, you know, we have actually started the process of co-design now. We again, you know, change is incremental, it's gradual. We know that we are going to need to sort of continue to improve this, but in a project that has just kicked off, we are seeing more consumers and carers participating in the process. We're seeing changes being made to building design in response to consumer and carer feedback. We're seeing consumers and carers also being involved in the design of hospital in the home and child and youth hope services, suicide prevention services. So this is very much a priority for the Royal Commission, and we are beginning to make the initial steps in learning how to do this. You know, I mean, it's sort of the word sort of slips off the tongue, but as I'm sure many people in this room will attest, it's actually a complex sort of process that requires a commitment, and it requires time, and it requires engagement, and you know, all of these things are not always immediately and simultaneously available, but we are again making steps in this direction.
Can I just jump in and support what Simon said, Natasha? Our new facility at Origin, which we waited 25 years for, was co-designed by 168 young people, and it's just a fabulous sort of environment. But already you can see. Yes, you know, some of the professional groups wanting to kind of bring in swipe cards, and it was designed with totally non-us and them sort of mentality, and already you can see that, you know, the kind of a tendency of people to want to just, you know, bring those barriers back in again. So I say it's like the washing up. You've got to keep doing it. You've got to keep involving the voice of the young people, in our case, in the process, and it's incredibly powerful voice, and it's been essential to the success of youth mental health models.
And isn't it about also training the next generation of health workers to know that they must listen and they must consult, and it's just part of the very practice that they do. This is the opportunity.
You get a better result. You get a better result. You really do.
Now, can I just add to that? Sorry to jump in.
Yeah, Lisa.
Just echoing what Pat had said, as well as Simon and Paula, I definitely agree that it's super important to have folks with lived experience and carers and families involved in the design of services, but also the delivery of services, and make sure people lived deployed within the service. And we've talked a lot tonight about the peer workforce as one example. But obviously there are other roles that people with lived experience can perform within an organisation. But also for me, it's really important that folks with lived experience, carers and families, are also involved in the overall governance of a service and determining what accountability frameworks look like. Because I think sometimes accountability frameworks prioritise what's important for the service from their kind of bureaucratic reporting point of view, but not necessarily outcomes that are focused on the people they're serving. So
give me an example of what that looks like. Strip it right back to how that would change the experience of people who are accessing those services, whether it be people who are experiencing mental illness or their loved ones or supporters.
Can I?
Do you want to jump in, Paula?
Yeah. Oh, go. You go, Simon.
Lisa. No, Lisa was going to. I'm putting it back to Lisa first, and then I'll come back to Paula. Yeah.
Well, I think it's something that hasn't been done well yet. So in terms of determining what it looks like, it feels a wee bit tricky. I mean, we have the Your Experience of Service survey, which is really starting to drill into the outcomes that are important to people with lived experience. And I think if we can start applying that, you know, as part of funding agreement, so that government is
your connection's a bit,
as well.
a bit funny, yeah.
Oh, really?
Keeps dropping out, but we've got you still. We're hanging on.
Good.
Dear life.
My connection's as tired as I am, I think.
Paula. Oh, sorry, go on.
Oh, no, go to Paula, that's fine.
Thanks, Natasha. Coming back to the role of peer workers, we ask people what it is that is happening or not happening. What would you like to see happen? And I've got a couple of examples of where we were able to give feedback back to the management. One of them was they were looking at the time. There was a lot of complaints about the delay in phone calls at night time from the acute team to people. And so the service took on board that. They looked at, this is back in the days where they had pages. So they looked into it all. And the end of it was that they changed companies because they were able to point that's where the problem was. So there was direct action on the feedback of consumers. There was also, I'm trying to think, but there was another one. But anyway, there was, so just getting peer workers, talking with people, getting that feedback, bringing it back to the management, and then seeing that action is done, then promoting that, which is that quality cycle with the S process, is that, you know, you promote what's been, what has happened from the feedback. It's really important to have that inclusiveness of as many people as possible.
So many questions and comments coming in. Thank you so much to all of you watching on, all something like 600 of you around the place. Catherine says, we need funding for co-design. It doesn't come for free. Yeah. Pay people for their time, for the coordination of this. This must be a priority in funding. Co-design and sensory modulation, what wonderful solutions to so many issues. Please let's also co-design and co-create sensory modulation interventions that are meaningful and enable meaningful change in people's lives. So lots of comments coming. I'm desperately trying to keep up with them all so that I can get them to you. Chris makes an interesting one. He joins us from the UK, and my overriding observation of, and thanks Chris for dialing in, my overriding observation of the Australian mental health system is a lack of scale. Too many tiny organisations make it confusing for patients to navigate and make it impossible to achieve economies of scale. It results in no one organisation having enough data to support patient care or do meaningful research. More funding could be achieved simply by combining services and replacing the resulting excess of managers and admin staff with more options. And maybe we could add to that, Chris, more peer. Pat?
Yeah, I'd love to support what Chris has said. And I think what we've seen with with the federal funding, with the advent of primary health networks, that's fragmented an already fragmented system even worse, because you've got this competitive tendering, you know, people fighting over scraps and PHN sharing love across their region and giving this agency 50 cents and another agency over there 50 cents. They were supposed to integrate care, and some of them have done that, to be fair, but the model of actually delivering and commissioning services really works against integration and scale. And you've got to have, if you want to deliver evidence-based care, you've got to have standardized programs that actually deliver and ensure that you get what works. And I mean, for example, in cancer or other major health areas, you're not allowed to just experiment around the edges with unproven things. You've got a responsibility to deliver what actually does work. And there's evidence for heaps of things in mental health which are not actually done. Other things are done.
Just to pick up on that, Pat, though, you're not meaning, though, by standardising, we're not talking about a kind of cookie cutter approach.
No, it's the opposite. Because
you want to meet the individual where they're at.
Well, totally, but you don't treat each new person as a completely different person from anyone that's ever been seen before. There are some common patterns that we know. That's why we do research, to find out what works. And in mental health, we just don't. In fact, we dismantle things that are proven to work, like, for example, home-based care and assertive community treatment. Those things were evidence-based, and they virtually disappeared, and they've been replaced by things like beds in emergency departments, for which there's no evidence that they're actually an effective approach. So we do the opposite of what they do in the rest of the health system. We do things just in a knee-jerk, sort of piecemeal and fragmented way, like Chris says.
So how do we change that, Simon?
Well, I think the Royal Commission has identified that that over the past 25 years, there's been quite a sustained neglect of the system, to the point where in Victoria, the expenditure, the per capita expenditure on mental health was the lowest in the country. And the Victorian government, has, and the Victorian community for that matter, has rejected what became, and I'm sort of quoting somebody else, the soft bigotry of low expectations. We actually stopped understanding what good looked like, and so the Commission has really been about trying to reestablish what that framework actually looks like. So we need to put more resources into the system, and we've seen that happening. We've seen the commitment from the Premier to implement the recommendations following the final report. This is really substantial. This is a substantial commitment, and we have every reason in the world to be incredibly excited by it. The pandemic notwithstanding, obviously, because that has of course been a completely unexpected development along the way. But so we need to the roadmap, I think, is sort of beginning to slowly emerge, and other states have done a lot of this work. But the notion of better community services, stepped care, available care. I mean, we've heard all of these solutions today, but the starting point is a community that accepts that this is a priority, and is willing to support world's best practice, and is ready to explore and understand and define what that means and what that looks like.
We have to get more positive stories out in our local communities, and have local community participation in all of those aspects. We have a partnership and promotion committee, and we have somebody from the council that sits on that. And so we've got a much better relationship with our local council. I think that's really important. We're able to talk about where the issues are in our community. For me, it took me 20 years of living in my community before I felt comfortable in actually going and playing bingo at my local club. But it's wonderful. I feel so much more connected to people in my community now. I see people when I go shopping and they'll say hello. I never had that in my life. So it has to happen when people are ready. We can't force people through that journey. So it is, we have to be available. We have to have services and people available for where people are at.
Yes, I'm listening attentively whilst also looking at everyone's questions. I want two frontline responder type questions. Robin, GPs are in the front line. Can we help GPs so they implement early intervention strategies more often and more effectively? So that's one question. Just hold that thought. Tim has asked, why are police first responders to mental health? So I guess they're two front lines that haven't been discussed so far. Who would like to respond to either of those?
I'll go.
Go for it, Pat.
Okay, can I take the police one first? Because back in the 90s, when deinstitutionalisation was really in full force, there were a lot of police shootings of mentally ill people, and a thing called Project Beacon was set up, which required the police, required mental health services and police to work together, and it was the mental health people that were the first responders. The police were in reserve. They were called upon as necessary, and it worked very well for a few years, and then it gradually fell away because of the system collapsing. And over time, we've had the police thrust into this role of first responders, which they're really poorly equipped mostly. I mean, sometimes they do quite a good job, but quite often they do a terrible job. And I've been involved in police training in the wake of the Tyler Cassidy shooting. And we spent weeks and weeks trying to train the police, but their training procedures are so rigid that it's not possible to actually make people safe under certain conditions, in my opinion. So I think we've got to take them out of the front line, which means heavy resourcing of mental health professionals whose job it is to actually be the first responders in the community. And if there's a need for police, they should be very much second line. The PACER model in Victoria, it does have one little mental health professional sitting in the back of a police car for a few hours a day, and that's seen currently as a solution. I think it's still back to front, actually. It's not fair to the police. It's certainly not fair to people with mental illness to be confronted with police as the first response. And unfortunately, the mental health professionals have taken a big step backwards over the years, which is maybe understandable because of the incredible, overwhelming demand they've had to deal with. But it's not okay. They are trained to do that, and they should be the ones that have the first response. And maybe with peer workers and other people involved, help soften that entry.
Lisa, family members are often in a situation where they don't know who else to call but police.
Yeah, it's something that's definitely touched our family over the years, and I think it's an incredibly complex situation. I think the necessity to do that very rarely emerges from anyone actually thinking that police are appropriate responders, but then, you know, as Pat kind of indicated, it's more from the fact that the system is not there when you need it. So crisis and assessment teams work within limited hours. Even during the day, they can still be quite limited in terms of whether they can attend or not. And then if it's after hours, then you're always kind of told that police and ambulance are your only options. But I actually want to take it one step further and talk about the justice system as a whole, because I think in terms of mental health advocacy, unfortunately, the justice system often falls into a bit of a black hole. It's not, you know, it's behind these massive walls and this barbed wire, and we often have very little visibility as to what's going on in that system. But for many people experiencing mental illness and psychological distress, when they make it into prison, sometimes that's the only mental health assessment and treatment that they've had, which again is a demonstration of our community systems or our acute systems' failure to actually intervene and prevent someone ending up in the justice system.
I think it's well recognised that prisons have in some ways become the quasi-psychiatric hospitals of the past.
Yeah, or the provider of last resort is another phrase that kind of gets talked about. But I think as a system operating under that paradigm, it's the complete antithesis of what we as a sector are trying to work towards in terms of promoting recovery, eliminating restrictive practices. There is so much going on in that setting that is just incredibly harmful and damaging to people and really needs attention and advocacy, I think.
We've got 7 minutes left and a bazillion questions. Thank you so much. This is just a sign that this is just the first of a number of webinars. So please keep coming back and joining in. And just so you know, we're recording this session. The themes team are, and so you'll be able to share it and watch it back. So let me just quickly come to some questions here. I'll just get to the section. Thank you so much for all. Everyone's commenting on what you're saying too, you see, so I'm just trying to... the GP's question, though, I think is vital. So, Paula.
Yeah, just Lisa talked earlier about, you know, the partnerships that are involved, and GPs and other private practitioners are so important to be working in partnership. I've heard clinicians say to people, oh, you know, oh no, you don't need a public service because you've got a private psychologist. But they're not always available when the person's in crisis, and they need to be part of that discussion. The psychiatrist decided to have a clinical care review on me, and he was actually shocked when my GP wanted to be there and my psychologist wanted to be there and I wanted to be there, God forbid. And I made sure I was there. I had to be by phone because I was in WA at the time on survey, but I thought it was really important that I had a say in what I thought had been happening over the previous 12 months. And my GP and my psychologist made an effort to be there. And the consumers, I had a forum last year where I asked the consumers about that, and they said they would love their GP to be able to have a say. They say they may not be able to go to the meeting, but they could put something in writing so that their voice is heard as well. And that sort of coordination of medication is so important, because so many people are having interactions with their medications, and that can be really harmful, you know, to the point of death. So it's really important that somebody's coordinating that.
And in some ways, you're the agent of change, making that team, building that team around you. Simon, you've got a comment to make.
Yeah, I was simply going to make the point, perhaps picking up on Paula's comments, that GPs often are looking for support for at times very complex situations, and so access to other services is really important. And Pat made the you know, a comment earlier on about the importance of creating structures and frameworks for multidisciplinary care within sort of the primary sector. And I think that's a really important element of reform that needs to come, you know, that where we create the capability so that you know, GPs can work in partnership with psychiatrists and psychologists, but also be remunerated for the time that they spend, not necessarily seeing somebody face to face, but talking about what is happening, and you know, planning care, and discussing complexities and difficulties, and working through problems, because that's not always properly remunerated. And so we just need to think about, well, what would multidisciplinary care looks like? And multidisciplinary care is absolutely, I think, you know, central to the delivery of successful mental health care. And it's what is so often lacking, both in the primary sector and in the specialist sector.
And so it's not just about all those disciplines of care within medicine or health. It's
beyond, yeah.
How do we reach out and make sure that the person who's delivering housing support?
Yep, that's correct.
What about the employment service?
Yeah. Can I agree with everything that Simon just said? I think the GPs need help. You know, that it's this missing middle concept, that there's a whole bunch of people that everyone's entitled to primary care, but there's a whole bunch of people who are, you know, who've got needs that are too complex for just a pure primary care, better access sort of model, but can't get into the incredibly restrictive state-funded system. So a whole bunch of people that need multidisciplinary care, and the GP is a key part of that, but they don't get the backup, and there's no way of delivering what Simon is saying at the moment. And I think the other thing I'd say about thing that systems totally failed to deliver, but is probably the most precious thing that I've ever heard, you know, hundreds and thousands of patients saying over the years, is the relationship with someone they can trust, a therapeutic relationship with, whether it's a case manager or a GP or a psychiatrist, whoever it is. That long-term relationship is incredibly important, but it's something the system doesn't even try to deliver. You know, we have changes of personnel all the time in the public sector, case managers, registrars, you name it, they're changing every 5 minutes. And so you never get any continuity. And yet it's the most precious therapeutic thing that's valued by so many people.
Yes. So that's about thinking about the system and how it's designed. It's also about better resourcing. Isn't it?
Yeah. And more thoughtful, more reflecting on what, and listening to what consumers will say to you. What's important to me.
You know, Ross, go, Paula.
In my early days of receiving care, my relationship with my case manager, well, now care coordinator, was the most important relationship I had. She was a woman close to my age. So as I started to catch up in my development, I guess she was able to share with me what real life was like, and I needed that. You know, she'd cop a lot of flack because, you know, oh, you're crossing boundaries and stuff. But, you know, if you've got a good clinician that knows how to steer that relationship, it can be the most successful part of recovery. And I found that was what happened for me. Yep.
Interestingly, Petra has commented, and I'm hoping we might be able to extend the session by a few more minutes if that's okay. Just letting the team know. Petra's written What about including family-sensitive practice that has a wider and supportive role? I do not think this is happening. The health services become so individualised. The role of the community, society, having a bigger perspective on social determinants of mental health. Lisa, you know, some people are very isolated in the system and perhaps they don't have family or loved ones to support them. So we need to acknowledge that as well. But people do have people around them sometimes that can offer that wider contextual support.
Yeah, definitely. And I think the identification of someone's carers, or I use the term carer because that's what's widely used. It's not a term that resonates with me personally, but you know, that services making an effort to actually identify someone's support network, whether it be their family of origin or other support people. And that's critical, not only to kind of share in the partnership of that care delivery, but it's also about providing support to families and carers, which is also really critical, so that they're enabled and empowered and have the education and the support they need to actually support their loved one. So yeah, I couldn't agree more. It's so important and so incredibly undercooked in the system currently.
Natasha,
Simon, yes,
I've got. I can certainly speak to an experience I had at the Alfred, where I worked before going to Mental Health Reform Victoria, where our Child and Youth Mental Health Service adopted a different model of care known as open dialogue, and that is basically an approach to care that centres around the consumer's network as defined by them, and it's usually essentially their family, and all decisions and all interactions occur through the network, and that's a really interesting model. I mean, it's one in which is still being studied and evaluated, and there's some degree of there's much more yet to learn about it, but it's a really interesting approach to mental health problems that basically builds on the strengths of existing friendship and family networks, and it's certainly one I think that holds some lessons and some interest for services right across the board. Lots to learn, and lots of sort of issues that come up and exceptions, and no doubt that would apply, but very much an interesting piece of work that's yielding some very effective results, I think.
I'm going to wrap with two questions. One question, but two comments. Marie's written, as a carer, the most challenging part of being a carer is not the person I care for, but dealing with the state mental health systems. And then we also have, from Ross, how can we break down the silos between public and private, state-funded and federal-funded, public mental health services and community managed organisations, hospital and community? I work in a community access team and I struggle to understand the systems. How do we make this simpler as we continue this conversation about reforming our mental health system across Australia?
Can I have a quick go at that, Natasha? I know we're running out of time. I think we've got to actually have these integrated service hubs in the community, which are, as Simon was saying, absolutely owned and supported, and Paula said this too, owned and trusted by the community, but by single agencies. So single agency captures federal and state dollars in terms of, block funding or whatever funding that is, and also employs, the private practitioners as contractors or practitioners within that kind of umbrella. And that's sort of what Headspace is in a very simple way, in a primary care way. The adult hubs being planned federally have got that potential as well. And I think it's very easy to see how this could actually take shape, and you could integrate services more. It's the opposite of what I said earlier that the PHNs are doing in terms of scattering the resources through different agencies. You try to integrate them, and you try to pool the funds, and you have multidisciplinary teams, which could include quite diverse areas, like you included housing, for example. There's no reason why you can't have those sorts of elements in such a holistic model. And then you get away from this, sterile debate about medical model versus non-medical model and splitting things into psychosocial and medical. You integrate everything that people need into one place.
We love our silos.
Yeah, we do. We do.
We're obsessed with silos. A final comment from you, Paula, and then Lisa, and then Simon.
Gosh, there's so much, but yeah, we need to look at how to integrate technology as well. You know, with COVID, we're doing a lot more telephoning people on online, and we need to I guess keep some of that as well, to keep people connected that haven't been connected. We also need things like apparently there's these wrist things that we can wear so that when we're asleep, the nurses don't have to come around and wake us up with the torch in the middle of the night, but you know, our vitals are recorded back on the computer. Like, why don't we have things like that? Because people being disrupted in the middle of the night is really annoying.
Technology. Well, the telehealth conversation is a big one, and I reckon that's almost really for another topic. Lisa and Simon, final comments to you.
I totally agree with Paula's comment around the band. There's organised South Australia that referred to that kind of concept, prioritising safety, not surveillance, and I think that's a really good example of that. But in response to what we've been talking about around integration and the current kind of fragmentation that we're seeing at the moment, at the risk of nerding out and regressing to my bureaucratic days, I would really love, I think the fragmentation is a reflection on the fragmentation that exists within government and government departments, and the fact that those silos exist in government and then it trickles down into the way services are delivered. So I would implore governments, state and federal, to elevate the complexity of the mental health system and all of the different solutions that need to be implemented in order to fix it and to actually deliver the outcomes that people deserve. I would love to see that elevated to First Ministry, so Prime Minister and Cabinet, and Premier and Cabinet in state. So that's my gunshot to them.
Great recommendation. Yay. Simon, are we going to see that delivered in Victoria?
Well, of course, the new Minister of Mental Health is the Deputy Premier, so I think that's
one step closer.
That's pretty good. We're pretty pleased with that. So look, I think I would perhaps furiously agree with everything that's been said so far, but I would say that 30 years in the system has taught me that that I think fixing the system is a journey. I'm not sure that there will ever be a destination, and I think we have to sort of be prepared for to continue to learn. This is why collaboration is so important. We have to move from an orientation to compliance and results to one of collaboration and creativity, because we will continually learn, we will continually improve, and we have to, keep an open mind in order to always be able to receive and learn from new ideas, whether they're within health, whether they're within, the biology of medicine, whether they're within sociology, design science, and so on and so forth. I mean, we have to look far and wide for the kinds of ideas that are going to make our system better, and we will never stop learning. The problem we had, I think, back in the day, was that we set and we then forgot. And we just let the whole system atrophy. In order for us to prevent this from happening, we have to continue to grow, and we have to continue to learn, and we have to continue to improve. And I would simply leave my comments at that.
And
we need to have hope for the individual and hope for the system.
Indeed.
Yes, and I guess this is what these sorts of conversations, particularly at this time where a lot of us are quite isolated, we're removed from all those supports that we might ordinarily access, physically removed, psychologically removed. And so these sorts of opportunities to come together as a wider community interested in the future of mental health services and what they look like and how we experience them is so vital. And I thank you all, Paula, Lisa, Pat and Simon, for being so generous with your time tonight and joining us from your kitchen tables, as I am.
Thank you.
I just want to let you know, to say that all the questions that came in, they will be used by the Themes team to shape the next webinars. So your comments and questions haven't been lost. They will be captured and thought about intensely. This event has been recorded. It will be used to inform future topics for future webinars. So please continue to sign on and register and come along to these sessions and offer your thoughts and feedback to the team. I'm sure they'd love to hear from you. Jane and Cheryl have put this together. They were overwhelmed as the registrations came in, upwards of 600. Thank you so much for joining us. Don't forget that this has been recorded. It'll go up on the Themes website. And Pat, Paula, Simon and Lisa, thank you so much. Have a great evening.
Thank you. Thank you. Good night, everybody.
Good night,
And from
everybody.
me, Natasha, thank you so much for joining us in the first Themes webinar event. It's wonderful to have you all sign on. Have a lovely night wherever you are in the world and stay in touch with us. Bye.
Bye-bye. Thank you.